Dr. Reena Sethi, you want to present cases?
Thank you.
Now I'd like to call upon Dr. Reena Sethi for her presentation paper FP41 on retrospective analysis of the hold the door technique of pinch, grasp and hold CCC. And Dr. Sabara, okay, Dr. Aditya Sethi is presenting on her behalf.
Thank you for this opportunity. Dr. Reena unfortunately could not be here.
Dr. Aditya, before you begin, I would like to inform you that because a change of presenter is really not allowed, so we would be marking you, but I do not think that it would be considered.
That's fine.
It's fine with you?
That's fine.
Okay, thank you.
Thank you. Thank you for the opportunity. So this is a novel twist to something which is regularly done. This is retrospective analysis of a technique called the hold the door, which is a pinch, grasp and hold of the CCC. So capsulorhexis we know is a critical step in cataract surgery and involves creating a round, centered and continuous curvilinear opening in the anterior lens capsule. Success of cataract surgery often depends on the effectiveness and safety of this procedure. Traditional CCC, we generally do manual tearing of the capsule using forceps or cystome, and it can be often inconsistent and challenging, especially in complicated cases. So we've had latest techniques like flax and Zepto, which has been developed to improve precision and safety of capsulorhexis, which has often been talked about, especially in complicated cases. However, they require additional instrumentation and not always are available or affordable in all settings everywhere. So came the advent of hold the door technique. Actually, it started with the intermittent cataract, where we thought this would be a little twist to what we normally did, and it made a lot of sense. So in this, the CCC, what we do is we aim to achieve a repeatable round capsulorhexis using basic standard cataract surgery instruments. So what we did is a retrospective analysis. We had 3 surgeons. We got their data of varying surgical experiences. So there was no surgical expertise bias in this study. We had about 350 cases. We categorized them into regular, which is something like an NS2 or a PSC or basic cataracts, routine cataracts. We also got a bunch of hard cataracts which are no glow or which were more difficult to do this procedure in. And we also had complicated like intumescent anterior plaque, small pupil. Those we categorized separately. So we basically gave everybody 7 cases where we trained them on this technique. We let that be the first 7 cases that they performed in the center. We measured the circularity diameter of rhexis with ImageJ software, and we had about 200 routine cataracts that we categorized, 80 the hard cataracts, complicated cataracts were about 70, and this was amongst all 3 surgeons. The surgeon received the basic first 7 cases which are taken out, and safety outcomes were evaluated and post their procedures. So results were, we had a high success rate of close to 99.5% of getting a repeatable round rhexis. In routine cataract, success rate was 99.5% with a mean circularity index of 0.96 and a mean diameter of 5.56, which is achieved in these cases. Hard white cataracts, the success rate was about 98.75 and the circularity index was a 0.94 and diameter was about 5.51, which was achieved. Complicated cataracts, the success rate dropped a little to 97.14 and mean circularity index was 0.92 and diameter was 5.45. The incidence of intraoperative complications was low and it was comparable to that of a traditional CCC. In routine cataracts, the incidence of posterior capsule was rupture was about 0.5, runout was 0.5%, ZD was 0. Hard white cataracts, the runout went up to 1.25%, posterior capsule rupture again 1.25%, and zonal dialysis 0.5%. And in complicated, we had a higher rate of PCR, 2.8%, and ZD was less than 1. So in discussion, it was simple, effective and efficient. Hold the door technique was very easily adopted by all these cataract surgeons without the need of additional instrumentation or training. Technique showed a high success rate and repeatability in routine hard complicated cataracts. So in complicated cataracts where this really matters, it can be challenging, risky in these situations. Hold the door technique showed a success rate of 97.14% and low incidence of PCR and ZD and run out. These results were comparable to those what Flax and Zepto reported and superior to those where traditional CCC was reported in complicated cataracts. So these are various articles which have been published in favor of Zepto and Flax, and there was one very nice article I found where we compared these techniques with the CCC, and it said that CCC fracture was superior to that of Flax. Selective laser capsulotomy, which was more stronger type of CCC, and this also said that there were often incomplete laser cuts, and this needed staining and often needed to be managed with the CCC after that. So in simple terms, just by holding the door, we have managed to do a great procedure, safe and effective and repeatable without adding extra instrumentation. So in conclusion, I'll just show a video because it's a surgery based. Let's see if I can forward this. Oh, it's there only. Can I get the video?
If you can have the video.
Yeah.
Is it running? It's likely to run.
Just 1 second, sorry.
We have time.
Can I get the video separately? I can forward it. Slide share पे करना पड़ेगा. Okay, I'll have to stop this, is it? All right. So by nicking first or by not holding the door, we often have runouts, and this is what we saw, that there was raised intraocular pressure, which basically happens in intermittent cataracts, and that can cause extra problems. And as soon as you make a nick, you end up causing tearing and Argentinian flag sign.
We'd like to have your technique.
Yeah, I'm writing that. Somehow I can't forward it.
Okay.
My job was just to show you the technique.
Okay.
Can I stop this and show the video? Isko band kar. Can you see my screen? Okay, perfect. So I'll be able to show you the technique here.
Just show us the technique.
Yes.
In very brief.
So
that's what we're interested in. Yes.
Yeah. Okay. So the idea is to pinch, grasp, turn, and then hold it till you get a circular rhexis wherever you can, and then you can come up. So in slow motion, what we are trying to do is, with the same instrument, we are pinching, we're grasping the anterior capsule. So this is often been done, but the idea here is to hold it and round it. So once you do that, there's no way that the rhexis runs out. And then you can take breaks, you can come out, you can get your OVDs back in if required, or you can continue as per your fluctuation. So I'll show this in certain. So another case where you had intumescent, leaky white. So as long as you're not fluctuating, you're holding. If you round it, and then you have a safe CCC thereafter, a routine safe CCC thereafter.
Okay, sir. Thank you. Thank you. I think we get the gist. And with that, of course, you are not being marked for this.